So I have the honor to present you some data. I want to talk on the clinics first, and then Michele is later going to give you some details on pathomechanisms. As you can see, there's a lot of people involved in this project, and I want to point out especially that Michele is here. You're going to hear him later. And also, it was my pleasure to meet Ignacio before. He was the only doctor from Southern America that's here. And also Bodo is here, of course. So thank you for the Data2 Foundation to bringing us here all together. This is really just great. Thank you. Let me quickly tell you how this story started. So we were looking for the monogenic cause of immunodeficiency and immune dysregulation in this pair of siblings from a non-related family. The girl had an SLE-like phenotype with polyarthritis and kidney involvement, and finally died from a cerebral bleeding at age 17. Whereas her brother, this boy, or man now, presented to our outpatient clinic with a CVID-like phenotype, really classical, with hypogammaglobulinemia, recurrent respiratory infections, chronic diarrhea, and also lymphoproliferation. And with the means of whole exome sequencing, we identified a compound heterozygous mutation in CXCR1 in this family. And what was so special about this index patient for us was that he did not have any vascular lesions. He had antibody deficiency, and he was adult, in contrast to most of the ADA2 deficient patients that have been described so far, because they are pediatric patients, most of them. So consequently, we screened a cohort of 181 adult and adolescent patients with CVID or any other kind of unclassified antibody deficiency, with or without vascular manifestations. And together with the index family, we have now put together a cohort of 11 ADA2 deficient patients, 4 female and 7 male. And you can see that the age of evaluation goes up to 51 years, which is quite an old cohort. And also the age at onset was not so early in our cohort, but with a median of 8 years. As you can also see, the mutations that we found are spread over the whole gene of CXCR1. Some of them have been reported, but there are a lot of novel mutations, also including 4 splice site mutations. And I think it's also important to look out for splice site mutations in the patients that we heard about before with unsolved genotype. So all those mutations, however, have the same effect on the protein level as far as we know. They all lead to absent ADA2 activity. And it's important to point out also that the patient that we found with the highest residual activity has actually a quite severe phenotype with recurrent strokes. So we don't see that there is a correlation between residual activity and the phenotype. And also in the 4 patients that we could get hold of the samples, we did not find a residual protein expression. And so we think that the mutations all lead to an absent protein expression. We don't see a genotype-phenotype correlation at all. So let me see what those patients actually have. So the vascular manifestations that ADA2 deficiency is actually so known for were only present in about 60% of our cohort, whereas we found hypodysgammaglobulinemia in all of the patients that manifested with recurrent infections in the vast majority of them. And we think that this is not only due to our selection bias of deliberately screening for antibody-deficient patients, but we think this is an intrinsic feature of the disease that is not being assessed sufficiently so far. We also found immune dysregulation in the whole entire cohort, mainly with non-infectious episodes of fever that have been described before, but also with 1 patient with severe neutropenias. Organ involvement was also present in the whole cohort, mainly consisting of splenomegaly. And we also saw some neurological features, and here this is not only residuals from strokes, because actually only 3 patients of our cohort had strokes, but it also includes cases of severe myositis, fibromyalgia, and muscular atrophy. Because we were so interested in the immunodeficiency part of this disease, we had a closer look at the B-cell phenotype. And as you can see, there's a trend towards low lymphocyte counts. And we also saw low B-cell counts in 5 patients. And there's a trend towards high naive B-cells, whereas the switched memory B-cells are low in all but one patient, and the one patient that has just normal switched memory B cells is actually an adolescent patient. So that's why we divide it here into adolescent and adult patient. Here in the immunoglobulin levels, you can see that all of them have low IgM levels that we have also heard in one of the talks before. And all but one patient had low IgG and low IgA levels. And if you look at this whole cluster of symptoms, we think that this is actually an intrinsic feature of ADA2 deficiency. And it cannot be only a class switch problem, because a lot of patients have been reported with low IgM levels. Actually, there seems a not sufficient coverage of the immunological features of the ADA2 deficient patients, because it seems not to be so much on the mind of the physicians. Not all of the patients have been assessed for the immunological phenotype, and also especially not the adult patients. Interestingly, we found that there seems to be a correlation of the B cell phenotype with inflammation. So these are data of two different patients. Here on the left side, you can find the IgG levels of a patient in blue and his CRP levels over time. So from age 17 to age 30, he was more compliant. He didn't receive immunoglobulin substitution. And you can see that his immunoglobulins are constantly falling, whereas his CRP values are raising. And interestingly, if you, in this patient, start an immunosuppressive therapy, which happened here with a steroid treatment, and here at time point 0 with anti-TNF treatment, you can see that the CRP is coming down as we wanted, and also the IgM levels are steadily increasing now for over a year of follow-up. So this is quite promising, and Michele is going to give you more details on the pathomechanisms of this. So last but not least, I want to come to the treatment. As we have an immunodeficient cohort, of course, a lot of antibiotics were used. 3 patients are actually also on constant antibiotic prophylaxis. Immunoglobulin substitution was used in over 80% of the cohort. And of course, we also use steroids and steroid-sparing drugs in about half of the cohort. Platelet inhibitors, we have had some discussion about this today already. We made the experience that stopping aspirin in one of the patients with known coronary heart disease led to a heart attack. So we continued platelet inhibition again in her, and I think this remains to be discussed. Also, one of the patients has a severe neutropenia. He's dependent on GM-CSF. He has also a severe lymphopenia. And in this patient, hematopoietic stem cell transplantation is considered. So in summary, we found that deficiency of ADA2 presents not only with vasculitis, but also with immunodeficiency of the B cell compartment that we think is an intrinsic feature of the disease. We think that patients with CVID or unclassified antibody deficiency should be screened for ADA2 deficiency. And as you saw before in our cohort, the B cell, class-switched memory B cells were always low in all but one patient in our cohort. We think that there is a correlation of the B cell phenotype with inflammation, which might also explain the normal values in some of the patients that were assessed for it. And we also think that anti-TNF alpha treatment might improve the immunological features over time, which is quite promising. And that's why we think that patients without vascular manifestations, but with high and steadily increased CRP levels, should be considered for anti-TNF alpha treatment. So far, there's no consensus about the use of platelet inhibitors, but we found before that maybe it's okay to just give aspirin. And this is also, I think, important for the adult patients that might have other problems, cardiac problems, and need the platelet inhibition. And we think that conservative management of the less severely affected patients has so far proven to be a safe and good choice for our adolescent and adult ADA2 patients, especially for the ones with late onset disease and the main feature of immunodeficiency. But hematopoietic stem cell transplantation should be considered in patients with the phenotype of bone marrow failure. So I hope I'm in time. I'm coming to the end. I want to thank you all for your attention. I want to thank the Data2 Foundation for this really great event here, and all the other collaborators that you can see here on the line, especially Michaela.